Hey there, and welcome to This Explainer. Today, we're unpacking a truly fascinating medical phenomenon. We are looking at a clinical disguise that fools doctors every single day. A condition where the body literally cannot stop itself from absorbing iron.
So, picture this. An endocrinologist, a fertility doctor, and a rheumatologist walk into a clinic. Sounds like the start of a joke, right? But imagine 3 of their patients walking in with completely unrelated complaints. Patient 1 is being evaluated for new-onset diabetes. Patient 2 is desperately seeking help for secondary infertility. And patient 3 is sitting there with recurrent, deep pain and swelling in their hands. On paper, these sound like entirely different worlds. But here is the incredible medical mystery we're solving today. All 3 of these patients could actually have the exact same underlying disease.
And the answer to that mystery is haemochromatosis. This disease is a genuine masterclass in how one single defective control mechanism can quietly poison organs across the entire body with toxic iron. It's a disease that announces itself through completely different specialist doors depending on exactly where the damage happens first. Today, we're going to build our understanding of this condition from the ground up, starting from absolute first principles.
Okay, let's dive into this. Part 1, the broken iron gatekeeper.
To really get this disease, you first have to understand a quirk of human biology. You know, the human body is amazing at a lot of things, but it has one major design flaw. We have absolutely no active mechanism to excrete excess iron. You can't sweat it out, you can't breathe it out, and your kidneys definitely don't filter it away. Because we can't get rid of it, our only real control point is managing how much iron we absorb from our food in the first place. Now, this is regulated by a hormone called hepcidin, which is produced by the liver. Think of hepcidin as the bouncer at the door of your intestines. When your body has enough iron, hepcidin steps up, blocks the door, and suppresses any further absorption.
But here's the catch. In haemochromatosis, that gatekeeper is fundamentally broken. This condition is basically a disease of hepcidin insufficiency. It's most commonly caused by mutations in the HFE gene, specifically the C282Y and H63D variants. Without adequate hepcidin signaling, the bouncer essentially falls asleep on the job. The gut just keeps absorbing iron, completely regardless of how much the body already has stockpiled. And remember, because we have no excretion pathway to compensate, that unopposed iron absorption just accumulates year after year, depositing progressively into your tissues. That's the entire disease in a nutshell, a gatekeeper that has stopped saying no, in a system with zero backup plans for getting rid of the excess.
Which brings us to part 2, systemic rust and organ deposition.
Because there is no organ-specific mechanism protecting one tissue over another, this excess iron simply deposits wherever it circulates. It literally rusts the body from the inside out, which perfectly explains our 3 mystery patients from earlier. In the liver, it causes hepatomegaly that progresses to frank cirrhosis. In the pancreas, it destroys insulin-producing tissue, causing diabetes. Bam! That's patient 1. In the pituitary and gonads, it causes testicular atrophy and hypogonadism. There's our infertility patient, patient 2. It deposits in the heart, causing failure. And in the joints, it creates a very specific arthropathy classically affecting the 2nd and 3rd knuckles. And yep, there is the hand pain of patient 3.
Now, you might have heard of the classic textbook triad of haemochromatosis: bronze, diabetes. This refers to skin hyperpigmentation, diabetes, and cirrhosis. The skin literally turns a bronze color from a combination of direct iron deposition and increased melanin production. But I want you to keep this in mind. This named triad simply represents the 3 most visible consequences of this exact same underlying process. The rusting is happening everywhere inside the body, even if you can only visibly see it on the skin.
So, why doesn't everyone with the gene get sick at the exact same rate? Let's look at part 3, the female protective shield.
Let's look at the numbers for a second. The C282Y homozygosity, the genetic mutation causing this whole thing, is surprisingly common. We're talking roughly 1 in 200 people of Northern European descent. But the actual clinical penetrance, meaning the number of people who actually go on to get sick, is genuinely low. Carrying the genotype and developing clinically overt disease are 2 completely different things.
And there's a profound difference between men and women here. The reason penetrance is so much lower in women isn't just random luck, it's entirely mechanistic. Regular menstrual blood loss provides an ongoing, natural physiological iron depletion pathway. Menstruating women are meaningfully protected from accumulating that same toxic iron burden as men over the same number of years. This is precisely why clinically overt haemochromatosis is classically diagnosed in men aged 40 to 60. But here is the big takeaway. Do not dismiss the possibility of this disease in a female patient. Just understand exactly why she might present a decade or two later or with much subtler symptoms than a man with the exact same genetic mutation.
And this brilliantly illustrates Part 4, Modern Diagnosis Without Biopsy.
Getting to a diagnosis starts with two simple first-line blood tests, serum transferrin saturation, or TSAT for short, and ferritin. Based on the current European Association for the Study of the Liver guidance, notice that transferrin saturation is the absolute critical early marker here because it actually rises before ferritin does. If a patient is homozygous for that C282Y mutation, you can diagnose provisional iron overload on these blood values alone. For women, you're looking for a TSAT above 45% and ferritin over 200. For men and postmenopausal women, it's a TSAT over 50% and ferritin over 300.
And the best part? You can make that diagnosis without ever requiring a biopsy. Liver biopsy used to be the gold standard, but it is no longer the default for C282Y homozygotes with elevated iron studies. Today, a biopsy or an MRI is mainly reserved for cases where the genotype isn't the classic mutation, or when you need to formally stage liver fibrosis for prognosis. Oh, and one really important note here. Current guidelines strongly advise against population-wide genetic screening. Why? Because it flags way too many low-penetrance carriers who are literally never going to get sick. Targeted family testing is absolutely the way to go.
All right, let's look at the fix in Part 5, Treatment and Organ Recovery.
Because the problem is too much iron in the blood, the most direct, refreshingly mechanical fix is simply removing the blood. This is therapeutic phlebotomy. It forces the body to draw down its toxic iron stores in the organs to replace those lost red blood cells. Treatment happens in two phases. First, you have the induction phase, regular, often weekly phlebotomy until the ferritin drops below 50 micrograms per liter. Then patients shift into a maintenance phase, aiming to keep ferritin below 100. And here is a highly practical tip. Once they're in that maintenance phase, this therapy can very often be safely converted into an ordinary community blood donation program. It's therapeutic for the patient, and it provides a vital resource to the community, win-win.
Now, here's an absolutely crucial point. Understanding what phlebotomy can and genuinely cannot reverse. It is incredibly effective at improving liver enzymes, reversing early hepatic fibrosis, and clearing up that bronze skin pigmentation. Those tissues show genuine, amazing recovery. But, and this is a huge but, endocrine complications like diabetes and infertility, as well as cardiac damage, only recover in about a quarter of patients. Most strikingly, phlebotomy has zero effect on established liver cirrhosis, and it doesn't lower the risk of liver cancer once that cirrhosis is present. Removing the iron stops the ongoing insult, for sure, but it does not erase the deep scars that have already formed.
This is exactly why early diagnosis is everything. It's also why proper management requires actively screening every single organ system the iron has already touched. You can't just remove the blood and call it a day. You have to check blood glucose, thyroid function, and gonadal function. You need to get a DEXA scan because of the associated osteoporosis risk, and crucially, because hemochromatosis carries the highest hepatocellular carcinoma risk of any cause of chronic liver disease, 6-monthly ultrasound surveillance is absolutely mandatory once cirrhosis is present.
We've covered a lot of ground today, from a broken hepcidin gatekeeper to systemic rusting, all the way to a wonderfully mechanical treatment. So the next time a patient's diabetes, infertility, or joint pain doesn't quite fit the usual textbook picture, I want you to remember this explainer and ask yourself this one simple question. Could one silent, decades-long process be quietly depositing iron in more than one place at once? With hemochromatosis, asking that single question is often the key to unlocking the entire diagnosis. Thanks so much for joining me on this explainer, and keep asking those brilliant questions.